test the balloon while the balloon is functional. Then the second is priming the tubing. So priming the tubing means so the fluid column should be the whole system should be filled with the fluid before inserting the catheter into the child. So the third is positioning the child. The fourth one is to insert the catheter. So the catheter is inserted to some 4 to 5 inches. Then one has to place the balloon, the retract the balloon once you have the resistance until the time to stop pulling. Then you have to give the enema. So the enema, you are giving the calculated dose of enema. If there is requirement of any additives, that will be given over the period of some 5 to 10 minutes. So it should be given, so it shouldn't be directly in the, shouldn't be too fast. Then the most important thing is the hold time. The hold time is after you administer the enema, after you finish the appropriate dose, the patient has to wait for a minimum of 10 to 20 minutes in order for the enema to work properly. So during this time, the catheter should be clamped and it shouldn't be withdrawn. Then the sixth step is the next sixth step is toilet sitting. Then after a period of 10 to 20 minutes, they are allowed to go to the toilet. And usually the sitting should be between sometimes between not 1 hour. They should wait for 1 hour. You should give them time. If the situation allows it, they should be given some sort of gaming or books, or even one has to allow them to do homework while they are sitting on the toilet. It should be more comfortable. The final step is the cleanup, because everything will be reusable. So the final is the cleanup. So if the first enema that not work, or there is an accident in between, so one has to do high colonic washouts. So this is normal routine enema. This is high colonic washouts. It should be done. And if one enema fluid doesn't work, you have to combine another forms of enema fluid, or you have to increase the dose of the enema. So as we have discussed so far, this is much of trial and error. So one has to do accordingly. So if patients become completely clean with the bowel management program, one can use a laxative time. So this is usually done during the break time, vacation time. And these are the patients like retroprostatic 50% chance of continence. Such patients always should be tried to use a laxative. That should be done in the summertime, and in order to avoid any accidents, and the success should be also demonstrated radiologically. So one also can add 15 or strict diets should be followed during the laxative trial. So this is a list of the different class of laxatives that are used or revised. But I think in our city we do have only a few of them. So once you have started patients, whether the cause is fecal and pseudo incontinence, through fecal incontinence with constipation, or through fecal incontinence without constipation, the follow-up is almost similar. What should be the follow-up? So the key for successful bowel management program is education and sensitivity from the medical team, and that's quality testing, and one should be patient before just finding any positive or encouraging results. So this is how patients in Boston Children's Hospital are being followed after the bowel management program initiated. So generally qualified bowel management program lasts for a period of 1 week, and by the end of this 1 week, usually one can find the appropriate regimen for particular patient. So on a daily basis, one has to list the amount of fluid given for the enema purpose. If there are any additives, the amount of additive given, and if there are any accidents, that will be listed. The second is the enema progress chart. On the enema progress chart, also the overall daily progress of the patient will be listed. Then this is actually done by trained nurses, and the physician visit this patient at least once per day and see the progress of the patient. And if there is any dose titration, treatment or treatment, that will be decided. So this is the laxative chart, enema chart, the dosage, and then there is a progress chart. So the problem is it feasible to apply set follow-up in our setting? So this will be points later on. So after a period of this bowel movement, the child gets older, with other parents are intervening with their privacy, so they need some sort of independence. So if the child wants independence in the bowel management program, there are two options. One is surgical option. This is a manual procedure. The non-surgical options are there are various enema kits. So this is a ready-made enema kit. So the child can control. There is a simple controlled inflating chamber, and one also can insert the catheter by herself, inflate the balloon. This is the hand-controlled device to allow for the flow of the enema fluids. The other is percutaneous costomy. These are the two options for non-surgical management in patients who opt for independence with bowel management. So coming to surgical management of these patients, surgery can be done for different purposes of this patient. One is for the administration of antigrade enema. So candidates for this are older patients who are under the age of 8 who wants independence with bowel with enema procedure. So the commonly procedure is a manual procedure. The other is a sigmoid resection. So the indication for this sigmoid resection is in patients with fecal incontinence, which is related to fecal constipation, which are where the conservative or where the standard management of this bowel management program fails, and the need for laxative becomes significantly higher, and when all this fail, one way can be opted for sigmoid resection. So the patient who benefits from this are those who have localized type of dilatation. Localization of they might benefit, but still this is a point of controversy. So because of the fecal incontinence is not fecal incontinence related to fecal infarction or constipation, this patient will be very total incontinence. So one should be quite sure when deciding the sigmoid or fecal condition of these particular patients. The others are reoperative attempts. So candidates for these reoperative attempts are those malformations with good prognosis, patients with good sacrum, good-looking arrangement, and if they dislocate, recommend on MRI application to come make it for reoperative attempts. So it's usually really research, particular patients, more than 50% of them will improve after research, provided that they fulfill this criteria, the rate of mislocate. Otherwise, we do have a bunch of surgical options for increasing the sphincter. So this all are values are tried on adult population, and even in adult population, there is a variable. And there are not studies in the pediatric population. There is not such satisfactory. So there are some newly emerging treatments, medications, and surgical options. So these are the first is plaque for containing fecal incontinence, patients every options of bowel management has failed. One can try fecal plaques to contain fecal incontinence, but still they are not effective, and they are less tolerable in the age group. But it has been tried in other populations. It's found to be quite effective. The others are drugs. This is perchloride. This is a serotonin receptor activator, or agonist and which are also has endocrinitic effect. So this has been studied extensively trials now from phase 3 of trial. So after giving it once, so the effects will last for more than 1 month. It is been shown to increase the bone movement as well as softening the stool. This is found to be quite effective in adult population with chronic constipation as well as irritable syndrome. This drug is chloride channel activator. So what it does is to increase the fluid circulation from the apical membrane as well as to increase the colonic motility. This is also has been studied in adult population. But there is some promising result in pediatric population. So the effect of this drug also lasts for more than a month. The other is intrasphenic botulinum toxins are in patients for who suffer from intractable type of constipation. It has been also tried on patients with neural defect as a promising result. And once it has been given, the effect will last more than 6 months. Other is surgical removal of non-functioning segment. This is under study. So this segment can identify based on radionuclide studies. Still, the evidence lacks to use this as a guide for the management of this patient. The other is biofeedback. So biofeedback is also something found to be quite effective, particularly in patients who are suffering from emergent type of bone dysfunction. And it has been tried in patients who are refractory for all other types of management. So this is like learning by reinforcement, where a patient is able to control the body function. There are different things to install, and the baby will be taught in the simple function, after verification, and what is important. Then they will control themselves in more than 70 to 80% of patients, but programs they have significant improvements. The other is sacral nerve stimulation. As you know, sacral nerve is the functions of bowel, as well as bladder, as the pelvic floor. So in patients who have undergone sacral nerve stimulation, they respond well to this sacral nerve stimulation also. The other is radio frequency energy delivery. This treatment has been approved by FDA from 2002, and what it does is deliver thermal source of radio frequency energy to the sleeper, where it results in biomodulation and decrease in collagen synthesis. So by that, patients will have some sort of sleeper function also. We found to be quite effective. The other is full implantable artificial sphincter. These are the other population that vary. So the rate of continence of artificial sphincter ranges from 40 to 75%. But in pediatric patients, it is under study, but this is also found to be some promising. There are special groups. So that means in a minor spiritual group, so that the bone function. This particular group depends on the level of the lesion. So high lesions, thoracic or thoracolumbar lesion, they have slow colonic motility without some rectal sensation. So there was a loss of voluntary sleeper and internal sleeper dysfunction for this patient, and they are prone for fecal loading, and there is something that's one. So the broad management option for this patient today minima is integrated conference enema program. Rather than lumbosacral lesions, they have slow left colonic transit time, is intact and arresting tone, and these patients are content. But the problem is the automatic nature of this small thing. So in order to avoid any accident with particular patient, they should be put on regular rectal stimulation. Other sacral lesions, they have some voluntary sphincter activity, some anorectal sensation patients that have this activity, and they are disposed for constipation. So you see the bowel management for this particular patient, and some will benefit from selected patient will benefit from antibiotic enemas. So finally coming to algorithm. So this is the algorithm that I found from the Indian Society of Pediatrics. So this is if the patient comes with a constipation, the first thing is one have to look for the red flag signs. If there are red flag signs, they should be investigated for organic pathology. There is no red flag sign. It's functional constipation according to the Rome criteria. It's functional constipation. If related to incontinence, then if it's related to incontinence, the first thing is to do disinfection with usually phosphoethyl glycol. This is the first line drug that's used for disinfection. Is orally will be given, and if it is successful, patient will be put on maintenance laxative therapy. So PG is the first line management. Those above the age of 1, but below the age of 1, it's indicated. Only oral laxative used for disinfection below the age of 1 is lactose. Okay, the other drugs are not recommended. So if you are successful with disinfection, you continue with the maintenance laxative therapy or counseling. Dietary advice and toilet training is quite important. So if they respond, just progressively titrate the dose of the laxative, and finally they should be reached. So in between, if there is reinfection, again, one has to go to the same process, the response, those one has to look for organicals. So this is the algorithm for functional constipation. This algorithm is from the European Society of Pediatric Gastroenterologists and Hepatologists and Nutritionists. So the first thing, the patient comes with incontinence. Was it functional incontinence or not? So if there is any suspicion of underlying disease, one has to be looked for organic cause. If there is no suspicion of underlying disorder, if the patient fulfill the voluntary or wrongful criteria for functional incontinence, then if it's yes, one has to go to the neurology, to the qualified bowel management program according to the local whatever. So, but if the patient doesn't fulfill these criteria, and if their age is below toilet training age, so they should be one to wait and see the progress of the patients. This is the algorithm for HSCD patients who have been operated in level of fecal incontinence. So the first thing is for sero histological examination. So based on the environment, you can rectal manometry or rectal examination. If the sensation and rectal function is intact, this means overall prognosis is good. So the next thing to do is in this particular patient is to have contrast enema. If contrast enema shows any dilatation, one has to investigate and rule out correctable cause of obstruction, like transitional bone pull through anastomotic stricture like that. If there is no correctable cause, but there is dilatation, one has to start them on high fiber diets, stimulant laxative because the problem is left colonic transit and stool softness even as needed. And it's showing persistence. And if there is no dilatation, and if the patient has normal sphincter function, one has to assess for motility disorder. So colonic transit studies will be done, and if there is hypermotility, one has to do constipating that, and anti-motility that should be given. So from the outset, the HSCD patient presents with fecal incontinence, but with a stated deficiency in sensation in the sphincter function, they should go directly to bowel management program. So at last, this is the British recommendation for active management of fecal incontinence in children. So if the patient presents with retentive type of fecal incontinence, the first management will provide is oral laxatives. Will give anyone. Some also might combine the two, and the last result is surgery. So if the patient presents with retentive type of incontinence, the first line of management is bowel management, bowel retaining programs, including fiber diets, and with this is behavioral medical evaluation, the feedback in the low parameters should be given. So these are the primary cause of drug-coordinated imaging. This practice, again, the first line of management usually is PG, electrolytes, as a magnesium citrate or mineral, which can be the primary option for the laxative. Okay, so the management of this particular patient is a multidisciplinary approach that consists of pediatric gastroenterologists, pediatric surgeons, child psychologists, pediatric physiotherapists, nutritionists, and a trained nurse with the bowel management program. So all us to come together in a good outcome. So if things are going smoothly and they are collaborated well, the outcome of this students is quite impressive, and most majority can respond for a period of 6 months to 1 year. This is my summary. Those are my reference. So thank you for everybody. How the floor is.
Thank you, Dr. Izzati. So it was an excellent presentation. My name is Wani. I am from University. Pediatric surgeon there. So the quite interesting. I made it in the morning. I tried to use please forgive my lack of experience in doing this thing, so I will try to improvise. We will learn. The topic is very interesting because it also I learned a lot of things from here because I operated one patient, actually two patients. One is 11-year-old, the other is 7-year-old, and both had chronic. It's a familial adenoma. So I did total colectomy and video analysis. So the biggest challenge I had was after they survived, the biggest problem was that one of the child persistently became unable to hold stool for more than 3 hours, and he was at night incontinent. So I tried most of the
younger one was able to control and he was fine and doing, but the older one had so it's difficult. So I also took lesson from here. I think the floor is now open for.
I think I will add some things so that after that's
Okay.
So thank you all. What I want to add is, as has been mentioned, fecal incontinence is not a lethal thing. Rather, it is a disease or a condition that affects really the quality of life. We have been trying to, we're doing surgeries in ARA patients and HSD patients, where just most of the time we're concentrating on the surgery. Like they were loaded, there were a lot of waiting patients, but after that, after they survive, are we really doing them? Are we really following them? Are we really caring them for post-operative complications? Especially this may be silly, but this really affects the child quality of life. In case of, as Dr. Fissa said, social anxiety. They are not most of them, because of the continuous incontinence, they have not started school. So this is not a simple thing that we should neglect. Rather, we should focus on this and try to improve the quality of life that in children that we are operating. So this is not this is very important topic. So as it has been mentioned, there are different types of fecal incontinence. Like the common one, mainly the epidemiology, as has been said, it is variable. But as a pediatric surgeon, what we see is the patients that we operate usually. But majority of the patients in the community are patients with this severe constipation because of different causes. And most of them are handled by pediatric surgeons, pediatricians rather. So they come to us when there is a need of ruling out these organic causes. Majority is both mainly the pseudo-incontinent patients. But some of them, some of them may have some organic causes. So in general, these are the patients that are handled by pediatric pediatricians. So it should be sort of a multidisciplinary approach in managing and approaching these patients. So the one that we are mostly encountering as a pediatric surgeon is the one with sort of through fecal incontinence, meaning somehow the anatomy and physiology of their control is impaired somehow because of the surgery, because of the anatomic condition in ARM. But the one that are in case of pseudo incontinence, these are patients who can maintain or who can pass by themselves voluntarily. So these are the patients, the good population where they can improve, especially. But for us, in case of pediatric surgeons and the patients that we see, we have to strive to make them like, we have to have dedicated team to strictly follow and manage them accordingly. There is no, I mean, there are different algorithms, but most of the patients may not fit in one algorithm. So the treatment is basically individualized. We have to, even the doses is like, there is starting dose, but we need to manipulate for each type of patient. So it's a very demanding, it's a teamwork basically, both from us and gastroenterologists, nurses, psychiatrists, child psychologists, all should be involved in managing this patient. So it is not just like a pediatric surgical disease condition, rather sort of basically pediatric gastroenterologists and surgeons should come together and manage these patients. So before you open the floor, I want Dr. Elbet to say something. She's a gastroenterologist, so say something about your experience and managing this patient.
Thank you so much. My name is Elbet. I'm a pediatric gastroenterology fellow, first year, second year fellow. So as you said, we oftentimes have patients with constipation, which is very common. And in my experience, I haven't seen as much patients with fecal incontinence, but we have few cases. And also my question was the difficulty that we have. We start the laxatives initially to just relieve the acute infection state and everything, but we have difficulty as to when to stop the laxatives afterwards. There will be requisite dilatation and everything. So we oftentimes either stop the laxatives early and the symptoms comes up, or we don't know for how long, and some patients are unnecessarily put on laxatives for a very long time. So can you say when exactly it should be guided by symptoms and follow-up of the patients? But we see improvements of the symptoms, but when you stop the laxatives, then the incontinence comes back. So do you suggest any specific recommendations for that? And yeah, as you said, like that, those patients are most of the patients that we handle, and the rest we refer to the surgical side for those who are already operated. And so I wish you could say something on that point.
Okay. Well, there is no specific guideline when to stop and when to continue this management, but what is recommended is the most important thing is first to categorize the patient into which categories of fecal incontinence or constipation that the patient fits into according to the different criteria. So one has to do at least abdominal X-ray and contrast study before initiating any forms of bowel management. So once that's made, if you consider functional constipation without stated functional or functional incontinence or serial incontinence, the first line management was to disinfect them, as you have seen. This should be done inpatient basis whenever possible. That is not, I don't think this is suitable in our setting, but after disinfection, either beginning with oral or with rectal enema, then we continue with maintenance therapy with laxatives. These laxatives, usually it can be, if we consider functional constipation, usually we prefer to give them stable types of laxative like bisacodyl. Then they will be followed monthly basis with an abdominal X-ray with the symptoms. And if symptoms improve, usually we will escalate the dose of bisacodyl gradually. So sudden stoppage of such medication is the result will be the reverse. So majority will respond within a period of 6 months, and the maximum you have to wait is for 1 year. 6 to 1 year, almost all patients will respond. But complete response is not possible always. And on top of this, one should follow strict diet and dietary advice as well as toilet training programs also important.
Just to add one other issue, like we have difficulty finding medications for constipation. Like we don't have Sena, we don't have cake, relax, they have to bring it from abroad. So we rely on the few laxatives just to manage constipation. So what's your experience regarding this?
See, this is what we find is lactulose, like as soon softener, basically in the bisacodyl. In the bisacodyl, there are suppository forms, there are pure forms. Currently, even only the tablet forms are available. So we have that problem. Like what's recommended in the worldwide in the guideline is not, the drugs are not available here. So I think that's also another issue that we have to strive. Like this is not that much expensive. These are, I mean, there it is available well, and these are the things that we have to.
Very much. Thank you for this topic, especially it's very important because I don't think it's a lot of years that we started pediatric surgery in months. Of course, we had pediatric surgeons for long, but with such amount of patients now we are operating in the near future because we have pediatric surgeons all over Ethiopia. We have a lot of patients that would have operated without seeing and would have resulted in such kind of problem. So I think it's a good topic to discuss, and I also have a few patients that I have challenged. I have called you a few times. I think one, I had the opportunity of seeing nationwide where one clinic operates, and running a bowel management program, as you said, it needs teamwork, and it's mainly the nurses' fault. Besides team, it needs infrastructure. You know, the patients will come and stay someplace. So there is some room that they have prepared where it's not going to be a patient's home, it's rather going to be a family room that the families would stay there and they would take 1 week to complete their course. And then the other thing is the availability of the drugs and the materials. And here, especially in Juma, for example, even we don't have a contrast study, let alone having those drugs, fancy drugs. But we will have a lot of patients. So I think the question that was in my mind was, one is we need nurses that work with us, and we have to think about training them. And it's not going to be somebody else's job, it's going to be our job. It's not going to be the nursing team that are going to treat them on, to train them on bowel management program, because bowel management program is very specifically pediatric surgeon or a pediatric gastroenterologist program. And because the patient's management is a trial and error in the week that they are going to stay, it's going to be different. We can kind of adopt whatever is done somewhere, but it must be something of ours, and we are the ones to take it. The other thing is, with the drug availability as well, maybe is there not something that the pediatric society, the pediatric surgery society should be doing? Because as you said, it's relatively cheap. By advocating and trying to find these drugs is one thing that I was thinking. The other was, what about trying to find a local solution? Because even if the drug is going to be imported, will everyone in Ethiopia be affording those drugs? Is another issue. Even let alone or other drugs, even the lactulose and the available drugs may not be affordable for some of our poor patients. So I think finding some locally available food types, dietary types that can help us in modifying the patients, or what could it be? So for this, what I was thinking was, could we do some kind of a multi-center study? Because the number of patients that we have at each of our sites could be very few. But if we kind of gather together and different hospitals, we kind of bring patients, or maybe there is a kind of a common tool that we follow to see our patients' progress. or kind of a clinical trial. I think it's possible because the IRB can, some IRB process we can pass, but it's possible. And with regards to the infrastructure, I think we also have to think about can we save some space for our patients that they can stay in the hospital and get the program running. So I think the questions are going to be a lot, but we have to find a solution. Otherwise, if we don't find a solution, even one question that I have, maybe that's something that you can help me, Dr. Dinadin, is you had a very nice follow-up tool. And how did you become successful in that thing? How did you communicate to the patient? How was that successful? How was that successful in the choice of the food that the patient was taking? Did you tell them the type of food, this is what you should eat, and this is what you should do? What helped you in the choice of those? Because Ethiopians, males especially, we have challenge in suggesting the food that we eat. I have difficulty choosing the different. I may choose, but it will be difficult. So, so how do we do that? It would be good if we also share your practice. Thank you very much.
As part of clarification, just I communicated with the father. The father of the child was quite committed, and I just gave example list of constipating types of food, and just I started on trial this food together with the parameters. So once they see their progress, so they stop those foods that provoke the colon, resulting in accident and the other types of storage. One food is introduced at a time, and then finally give the type of the food that result in solid well formed 28 2 stores per day. So they stick to that strict dietary protocol. For the follow-up, the diarrhea, I give him, I just write the things that I want on the follow-up, just like in type of, I give him a table, but the father modified by himself. This table was read by the father. So my list was quite extensive, but short and eating. The first one, he just write the list of the food items that the child feeds, the 3 meals, then the time at which he has accident or time at which the students passed and the constants of the stool, another table, and the overall frequency of stool per day. So that just following system. Actually, I followed almost for 5 months or like that. This is the last chart, but if you have seen the previous chart, almost as multiple episodes of care was passing for 5-6 times per day. So later on, by trial and error, just we have found specific type of foods that is compatible with this condition.
Thank you. Any questions?
Thank you. My question is in the classification of fecal incontinence, pseudo incontinence and true fecal incontinence with constipation. How are these two things different?
So the difference is on the colon. The colon in patient with true fecal incontinence with fecal infarction is quite dilated, so they have motility problem in that dilated part of the segment. But in pseudo incontinence folks, they don't have problem with colonic motility, but the colon is quite a normal caliber. The difference is that otherwise, these are the patients, particularly true fecal incontinence. These constipations are patients who have been operated for anorectal malformation, which anorectal malformation is thought to have some good prognosis, but due to the intrinsic motility problem of that segment of the body, in the rate of segment, they suffer from these types of incontinence. But in the long run, so if these patients are not managed properly, they will behave like the patient with pseudo incontinence. So in the long run, if you find patients with this type of anomaly, with neglected constipation, you find them during the RSI, they'll behave like patient with pseudo incontinence.
Somehow it's
The current understanding of fecal incontinences, there are pseudo incontinence, meaning that the patients have normal anatomy, like the bowel, the sphincter mechanism, the muscles are there, but because of behavior of too many factors, they become incontinent. because overflow basically. But in case of organic causes, like these are the true incontinence, some part is missing, like in the muscle, in the colon, or in the nervous system, like ARM low type. They have some sphincter mechanism, but because of long-standing or dilated colon, they have the capacity. These are hypomotile colon. So in these patients, like they act as pseudo incontinences, but they cannot be like 100% normal anatomy. So they are considered as true incontinence with constipation type or hypomotile type of.
So maybe zero incontinence is, as Dr. Whipple said, are those patients who have the elements to maintain continence, but due to the behavior of the product in hypomotile colon, there is usually huge fecal filling the rectum, and there is overflowing incontinence. So there is another spectrum. In the other end, there are patients who have a very motile colon, which overwhelms the capacity of the sphincter in the sensory mechanism. So unless you control this loud, the other elements of continence will not be effective. So mostly what we see is these patients have severe constipation with overflowing incontinence. You call it incontinence. Some people use the term incomposes. Okay, they usually have small amount of stool staining the underwear, but the most of the stool is retained inside the colon. So the goal here is to treat the constipation. So there is an overlap in the constipation and fecal incontinence, and the presentation also has an overlap. So mostly we use laxatives in patients who have hypomotile type of incontinence, whether it's pseudo or true incontinence. The laxatives are used initially to disimpact the colon and see the effect. When you disimpact the rectum and the colon, if the fecaloma is gone, if these patients have the capacity to maintain continence, then when you remove the constipation, they become continent. These are the group of patients who are considered to have pseudo incontinence. So you use the laxative, want to disimpact the bowel and see the outcome. After disimpaction, they persist to have incontinence, these are no more patients who are no more considered pseudo incontinent. They are true incontinence. So the laxative is out of the equation and they are not treated with a laxative. But if they maintain continence after disimpaction, then it's not incontinence. Now you are engaged in managing constipation. So when you have constipation, functional constipation, particularly the duration matters regarding the treatment duration. So when you have a recent onset functional constipation, that is to say, if the duration is in some literatures, they say it's less than 12 weeks, some 8 weeks. If it is short duration, recent onset, it's not a problem. It's not a problem. Bowel retraining is not conducted. Usually, there is some inciting problem, and these patients can be managed with diet, bowel training, bowel habit training, and maybe sometimes patients may require laxative. This is a short duration and does not treat heartburn. But those patients who have a chronic functional constipation, these are really the type of patients which need to be followed closely, and they ask it regarding the heartburn. So usually, once you have achieved the type of stool that you want, usually the goal here is to have 2 to 3 or 4 minutes, but soft stools per day without straining and without an accident. This is the goal of managing constipation. So once you have reached this level, usually the duration of treatment is it should last for 3 to 6 months minimum. Then after, if you have managed these patients successfully with the goal stuff we have stated, then you start tampering. Usually you reduce small amount of the laxative use every 2 weeks. Okay, you reduce it every 2 weeks so that it can be tampered and discontinued. But at the same time, laxative is not only the only component of treatment. In these patients, they need to have training, bowel habit training. Usually, they should have a regular timed defecation. We are talking about patients who have reached the age of toilet training. That is at the age of maybe 3 to 4 years. Usually, they say it's 4 years. So in these patients, they should be able to defecate regularly. It should be timed. It should be monitored by the parents, like Dr. Zine, this chart. So they should time it. So the usual best time for defecation is usually immediately after a meal, preferably after breakfast, maybe lunch and dinner. So they should have. And the third component of treatment is the fiber content of the stool. Okay, so they should be advised. So don't for patients who have 3 incontinence, the diet you want is a constipating diet for hypermortality. For these patients, we need high fiber diet. So the fiber content of the food has to be improved. So there are several food items which can be recommended. So it should have a balanced but high fiber diet. The fiber content, they say you can calculate it usually 1.5 gram per kg, usually 0.5 gram per kg. But the easiest thing is you can use 10 to 15 plus the age of the child. So usually avocado, if you have one regular sized avocado, it's safe to have 2 to 3 grams of fiber in it. So potato, if it's not peeled, it has a similar content. So you can mix the diet and you can have a successful fiber. So with this, then you gradually happen. The food remains, but the laxative is withdrawn. Okay, with time. So it may take a year. Sometimes remember, even functional constipation, that is the most frequent problem we have. Functional constipation chronic can be lifelong. The management, the laxative could be lifelong. So that's something we need to stress. So for the baby to socialize and to be independent, we need to know the magnitude and the parents have to know the magnitude. The most common problem I have in my patients is the baby improves, starts to gain weight, the parents are comfortable, and they disappear from follow-up. And most probably he will come back. Well, he might have gone to another physician. So with a recurrent constipation. So we need to stress and tell the parents. So this journey is going to be long, but it's going to be fruitful. So because these patients are manageable, mostly they are manageable. More than 90% of patients who have functional chronic constipation, they are managed with the regimens we discussed. Thank you.
Thank you. Do we have any other questions? I would like to emphasize on a few things and then the classification is the most important as this is a ARN or HSD related this structure. So when functional components with retention or without retention, the management. But as a pediatric surgeon, our biggest worry would be for those with anorectal malformation, because these are somehow start before the surgery, and it's mostly the surgery that results in the complication in the leg. So emphasizing on the techniques and the type and the prognosis and the like matters. My question in my experience is, usually I have seen quite a few patients from 3-year-old to 21-year-old patient with ARN, and their colon size is more than 16 centimeters. And in the case of the 21-year-old, the other is 13 centimeters. In this case, the image that you brought with localized colonic dilatation is something that I have not seen based on my experience. What happens is the whole entire colon dilates, so you don't have room. In this regard, resulting anastomosis is something I don't know, maybe. But what I did was diverting colostomy completely for at least 1 year, so that the colon rests and recalibrates. This is the management I found working effective for both these patients, and it has resized, but initially it was even difficult to bring out as a in colostomy, so it was blowout after 3-4 months. Then we can colostomy. Then it recalibrated back after a year. Usually I give it maybe 9 to 12 months. Then it normalizes. The same thing, high content will be evacuated and it normalizes. Then the ARN works. The adult one was a female with vestibular fistula, and now she is fully content and it is okay. What my experience is that disimpacting it with colonic enema, I don't think it does work in my experience because the colon entirely is filled with feces, and then it is dilated and hypovolemic. So whatever you put in, it just stays there. So rather than irrigating, what I would suggest is enema, you can irrigate, aspirate, or sometimes in my experience, I take that to the OR, I evacuate everything in the colon under even sometimes I need to use some sort of scoop or something to evacuate the feces. Otherwise, it's not effective in enema way. Our experience is this: the younger boy was the one with ARM, with perineal fistula. It was done 5 years ago somewhere. I don't know that he had stenosis. So dilatation was not properly done. Here, what I suggest is if it is perineal fistula, usually a bit wider caliber. Anoplasty is better always. Usually, rather than making it smaller, relatively wider to the age is better, and then routine dilatation in that case, and making sure that these patients really adhere to strict anal dilatation is important. In that child, I couldn't be able to remove everything before the end. So I had to take him to the OR, evacuate, but colon was persistent. So it takes at least more than a year or so to return back the colon, and it still is on our management. So my question is, do you really still favor resecting anastomosis? I don't think it does good.
Actually, sigmoid resection is recommended only for those localized types of sigmoid dilatation. So this particular patient also, treatment dilation is quite important, and we have to make sure that because of this incontinence is related to a number of dilated recursive. But otherwise, as you mentioned, for those with global dilatation, colostrum is one of the options. You mentioned will be the practice also. So algorithms also recommend stoma, even ileostomy, certain types of.
Yes, in the West they practice ileostomy.
This resection will be recommended is for those patients who have functional constipation is hugely dilated rectosigmoid and have the capacity to control. Now the other patients, the resection you have to be careful if you are planning to resect the rectosigmoid.
In ARM, just one,
It did not have. So
I just to comment
Okay.
on in ARM, in HS patient, when we deal with fecal incontinence, the first thing is we have to rule out any surgical complications. As you mentioned, you said stenosis. In case of HSD, it could be retained ganglionosis that results overflow incontinence. So bear in mind, what we are discussing is after doing every surgery, like after we are exhausting the complications of this post-op procedures, and then if we are unable to control, that's what we are dealing with. So just clear that.
Thank you so much, Dr. Zinedine and Dr. for the nice presentation. Very excellent description. I think for me, constipation and fecal incontinence, they look different in situ, but it's the same spectrum. So it's, I believe, especially constipation is an overlooked disease condition, because we rarely see, especially the presentation at early stages of the disease, because most of the time we get these patients after they develop some sort of incompressis or some sort of dilatation with significant or some degree of abdominal extension. So I think the presence of the gastroenterologist here would be a very good thing for the future, because this will definitely like to have early consultations and some sort of manifestation. That's a very interesting. Oh, my comment and my question is, especially a patient who presents with significant fecaloma, and as Dr. Ondemage said, it would be even difficult to do enema. especially this kind of patients might not be successfully treated with medical disinfection. So we need to have either manual kind of disinfection or some sort of diversion. And the other issue is patients we have to also like the choice of the drug, the laxative should be also, I think, individualized, especially this should be kind of osmotic laxative. Otherwise, stimulant laxatives will worsen the condition or might significantly create some abdominal discomfort, abdominal pain, and so on. So, it's like isacodyl and sena should be included in the maintenance form of treatment. It shouldn't be the initial phase of disinfection. Probably one of the questions is we had previous discussions, we have developed also some protocol, and we have been saying that some 2 years back, and bisacodyl is not also safe drug until 4 years of age, and you have some maybe I don't know new thing or new update about that because we don't it is the efficacy not studied, and are we using it like a pill or body? The other question is when do you decide to proceed with anti-grade form of when should be the time, and how should you actually sometimes personally also I have getting difficulties decide when should do marrow procedure and so on. So I think this is one of the difficulties, especially in the patient with myelodysplasia and neuroactive effects, but it's most of the time it's a double incontinence. So it's actually a very difficult decision to do a bowel management program because this kind of patients needs lifetime bowel management program, and they have to be on some sort of antibiotic. So that's comment to the question. So
Do we have any experience in Malun? Okay. Some patients?
5, 6 or around maybe. Maybe number.
Even the patients who have bowel management program trained for a malon to be successful. We
Initially,
must have those.
yeah, the question is when should we do the antigrade? Basically, these patients are patients that are definitely incontinent for life. Usually the patients with myelodysplasia or spinal problems. So in these patients, first they have to be adherent to the retrograde. And when the time comes, usually this is low, like you do retrograde enema when they are younger. But as the age increases, like they want to be independent, especially above the age of 7 years of, like when they are in adolescence, it's difficult to do enema. So the retrograde fashion. So above the 7 years of age, if you claim that this patient is definitely true incontinent, you can do the malon. And first of all, they have to be compliant to the retrograde enema. I think that answers the question.
Maybe
right?
for one question, in amount different, like in Western, right, they have those gadgets.
Usually parents do that, right?
Yeah, parents will advise that use.
Yes. Yeah. Basically, what we advise for retrograde, for instance, for retrograde enema or basically anticoagulant, some patients may afford NS, but we like it is costly, especially at this time. So as Zinedine was presenting, they can prepare the saline at home. Just you have to boil the water and then cool it down like warm and hot. Then add some salt, like half a spoon or 3/4 of a teaspoon should be added. Then they have not only one tubes, but plenty of tubes. At least the minimum 5 up to 10 tubes actually is preferable, just like we do for Mitrophane patients. So using that, the lubricants will be available. So after that, they can using syringe. We demonstrate them, and also we show them some videos. Basically, most of the time, after they are comfortable, and during the malon procedure, we can show them while they are in the ward. But for the retrograde one, we demonstrate, and also even like Foley catheter with Yaska, it's not easy. ለእኛ እንደሚመስለን እነሱ አይደለም። ሶ ኮምፈርተብል that's what I do ካቴተሩን አስገብተው ምን እንደሚያደርጉ ሪሄርስ እንዲያደርጉ አደርጋቸዋለሁ። እንጽፍላቸዋለን ስቴፕ ባይ ስቴፕ ኤንድ ቪዲዮ ኦልሶ ቪዲዮ ሾርት ቪዲዮዎች ዩቲዩብ ሞልቷል፣ እሱን እናሳያቸዋለን። ሶ ኮምፈርተብል ሲሆኑ we can send them to home. That's my experience. I don't know fish, that's what I do. So basically like with local, that's what we do. It should not be under sterile technique, it's under clean technique. So
Yeah.
basically
They can use
Okay.
simply plain tap water.
Yeah.
Add some fuel salt, doesn't really matter. Doesn't have to be precise.
it,
It's just, so you can use maybe.
So you have to be careful when you advise patients to prepare saline at home. So the amount of saline they put, I've seen when I was in India, a baby died of hypernatremia due to the irrigation fluid they gave them. So they put a lot of salt, and they boiled the water for hours, and they used it for irrigation, and they died of hypernatremia. So you have to be, so
I don't know this, but I rather ask them to just do with plain. I don't ask them to put salt.
that's hypotonic.
the electric bill now has spiked.
I did not really see this, especially if it is irrigation. I ask them to irrigate. It doesn't stay in the colon long as enema. I usually use this for all Hashimoto's disease patients as an irrigation. I start them right away irrigation, and usually in hospital illness, if I would consider this as a primary put-through, then they can do this at home. They are administered after maybe 5-10 minutes, they will evacuate. And I did not really find this theoretical significant.
This is also especially careful with the dosage of the enema that is being administered. So but there is no ideal dose of enema, but the standard, there is no strict guidelines. I think it can be home-based. Some mentioned, home-based saline should be strict, so they shouldn't touch more than 1.5 teaspoon of salt in 1 liter of water, and you shouldn't give them more than 10 to 20 ml per kg. So some patients might require significantly large amounts of enema to evacuate their bowel, but in this patient, they should be followed for electrolyte disturbance as well as for evidence derivation. So as a baseline for our community, I think it's better to stick with 10 to 20 ml per kg of strictly home-based normal saline.
Usually, if you notice 10 to 20 ml is very small.
Yeah, when they prefer is also different very with illness in the bar.
Okay.
And where it's responsible than where the other patients there. Especially when you do it at home by a woman and extra patient. And when you don't know the patients in also the important period that we are going through. So this is what we need to inside. When you are doing in our present language, one thing you are doing for yes, like as part of the information and so on. But when they are doing it at all, that's when you very strict. Yeah, but the way you do that now, information.
It's just my experience, not suggestion.
Okay, I think so. Don't confuse it. So for patients who have on bar management program, the amount and composition of the irrigation fluid used, the enema fluid used, depends on the after you trial and error. So the amount and composition, which keeps the baby clean for 24 hours, is better. That is irrigation fluid before. But for other patients, the starting point usually for patients which is preparing for primary food, so you can use it. Initial point 10 to 20 milligram, but the other is different. So you cannot, so it depends on the successful.
Now, let's see then the piece of process for this in our school. And mostly when I try to speak, especially in plants, this is flaxseed and piece of process, which what's
Yes.
Piece of salt.
So, okay, yeah,
Something.
this is quite an experience for everybody. They do this especially professional visits. That not diagnosed early. Mostly they have this blast experience.
Rather,
Oh,
I understand what you're saying. So this part, the content is less. This sort of osmotic enema, but we cannot advise this because the safety issue, it's not, it's not, we don't know the safety for the kids, so it is, we cannot, as a physician, we cannot advise. Rather, there is a prepared glycerin suppositories that can be used. In that case, we can advise, but there is a glycerin, focused glycerin area. Again, there are other additive components in the soap that may have some effect on the patient, so we cannot advise as the physicians. Sorry.
yeah,
They don't use the soap as a suppository, they just use it for a sort of stimulation.
for stimulation.
So
The experience
of that is only different from the food or something else. That's some more of the otherwise doesn't matter. So my reading this soap is shouldn't be there. There are reports of gold or significant in other populations, we used to use soap previously in other populations. Now the recommendation is not use soap. But I think from our discussion, it seems that we have to have a sort of guideline, perhaps in by this school. Now, this morning I'm really very happy because there are so many pediatric surgeons in the room. Now the number is increasing, so we have to work on some extra.
We have a guide.
Previously, we were working with our patients. Now there are so many people and then you can do something outside the box.
We have a guideline and in by the pediatric unit in the department, there is a guideline that's prepared. Yes, but that is not validated. It should be disseminated for you, and then we need your inputs.
Yeah.
So to improve it, and then
Nationally.
yes. So I think we will disseminate that through the association, and then we can validate. I think that's a good point.
And the guidelines that we have from the international community, we can also easily adopt some. It's difficult to get some of the drugs, but still excluding the drugs, there is a problem.
regarding that, any experience, because what I see, the diet in the West and the diet in our community is completely different. It's fiber rich. It's not maybe too maybe liquid or Spanish, but it's well formed. And that also helps in airing or in air school. Do you have any suggestion besides what you suggested here?
That was an important impact actually.
Because we cannot really transcribe anything.
From the data that are available in our savings, one can select the motility of the column, the check, one can select from the locally available food items. We want listed is a list of constipating persons. Some foods that should be avoided. So from those lists, one can. So the thing is, even this is not a strict. So the food items that are listed as constipating might not work in certain patients. So that's why we say that even if there are some guidelines, it is much of trial and error. So the food items, one food item will be introduced at a time, see the condition of the patient, in which that doesn't work, then change that food item to the hazard. And once the baby becomes socially immune for period of 2 to 3 days, then that's the time to try an additional food. It's much
On that, can you say something on the review surgeries?
You have a list of reviews on this.
Yes, yeah, there is.
Yeah.
They really work.
So from what I come across, the only thing that work best is radio PCR in patient with good prognosis where the rectum is misplaced. Otherwise, most of the other procedures, typically focus on ischemic neuroplasties, are done on adult population, and the studies are more extensive on adult population. Evidence likely to be common specific types of plastic or any split that split plastic pediatric population.
You say that the you were saying that the diet habit is different for us and for the Western countries. And they have their own definition of constipation. I would say that constipation is like someone that's to the reason for so are we going to adopt that same definition for CETA or shall we have?
Meaning the definition, their own definition, or
Sometimes, like in clinic, I got a child who is passing good twice per week and is quite comfortable. If the mother has similar distress, the mother and she said, "Oh, I have similar one." So shall we adopt that definition or should we have another?
I think as I mentioned previously, we need a local study about the normal frequency food party nursing. Then probably we might have our own definition. But as to what's currently actually their own classification, want us to pass more than 3 times per at least.
And the frequency is a component of the definition. Yes, so it needs to have at least 2.
Okay.
I think ምክንያቱ ለምንድን ነው ይሄን ያልኩበት ምክንያት ሜቢ ሮንግ ስፔሲፊካሊ ፎር ዛት ፔሸንት በት ዳይት የሚለው እዛ ውስጥ ኢኩዌሽን ውስጥ ይገባል ነው ኮመን ዳይት ያ ስለሆነ ማለት ነው እና I think I really want the guideline that are prepared because አንድ መስመር ብቻ አይደለም ያለው መልቲፕል ዳይሬክሽናል አልጎሪትም ያለው እና ያም እንደ ሪሰርችም ቢሆን ምክንያቱም ሪሊ አውትካማችን ቢታይ እና አውትካም ቤዝድ የሆነ ኤቪደንስ ቤዝድ የሆነ ደግሞ ፕራክቲስ ነገር ቢመጣ ጥሩ ሳይንስ ኖት ኦንሊ ጀስት ፎር ፕራክቲስ ዶክመንት ብናደርግ ለዛ
to say few things. If the mother says the child is passing twice once a week, growing, no distension, pattern, and it's fine. Maybe he's an outlier. We don't have to really compact everything into categories. There is always spectrum. So we need to have room for this kind of things. And the rest, we need to have our own baseline data from school children and the like, then we can extrapolate from that. Otherwise, until then, we cannot really say anything.
Together with what conflict is child count?
Usually the mother and that is passing once like every Saturday morning, then I ask, is there any history of constipation? Either the father or the mother? Actually, it's usually all of them have the father or the mother, they are leaving the comfortable with their constipation, but they bring the child in with somebody from the village or not with, oh, this child is not passing, this is wrong. Otherwise, when I see the child, he has no distension and he's quite no alopecia.
Yeah, one has to know that the definition of constipation in that exercise. That's why such good videos. We need, I think this is various areas of research. We still understand.
Yeah.
Should make our own study, like our own standards.
That's wrong for criteria. Actually, it's not only the frequency, there are also certain criteria. I think you have to look specific wrongs for criteria to diagnose functional constipation. Actually, most of the functional constipations are benign. There are no structural abnormalities, the abnormalities, and so on. So, anyways, we have to look the details of for criteria, and we can revise and customize our code product to our local practice.
Thank you. It was a very nice presentation and discussion. So I just wanted to say, like, I was part of developing this, and for the fecal incontinence. So, I mean, very good, I wish we can all see the family comment. So try to put like the food items. I mean, customize it for our second game, but you can amount so that we can share the patients and well, I've seen from the patient side, I found it to be effective. The problem is that most diets, mostly most probably local use items on which so it's sleeping the giant, but the ones I didn't think that I have stuff. And so that's even if it works, it's still difficult for the ones to compare with that. And the other thing is, even if there is a guideline, I mean, I still see that the education from our part is lacking. So these patients need, if we can't see them for 5 minutes in the clinic and then send them home, we really have to take the time evaluating them and then counseling them, managing them, and yeah, even people are hesitant to this to send for some of the investigations to describe some of the medications because even us we are not very versed in this area. So I think it is something that work from us pediatric surgeons also.
If there are any more questions, then I thank the presenters and the audience for this lovely.
Actually, just a reminder,